Our next speaker is Dr. Kavita Babu. She's an assistant professor and director of medical toxicology fellowship in the Department of Emergency Medicine at the University of Massachusetts Medical School. Welcome, and you'll be speaking about hard conversations addressing patients with chronic pain.
Thank you, Dr. Saxon. So, thank you for the opportunity to speak with you today. I'm cut from a slightly different cloth than a lot of the speakers that you'll be hearing from today. I think of myself primarily as an educator, but I think that this difficult topic that we're going to talk about next is critical because where I think a lot of the implementation of the great recommendations, of the screening tools, of the treatment paradigms fall apart is at the bedside. And perhaps all of you have seen that happen where you go in with a clear-cut plan for what you're going to do for analgesia with the patient, and then the human interaction changes that plan. This is a thorny problem. And so to get some input into this bedside dilemma, what I did was I emailed my residents. And I asked them this question: what is the single most difficult aspect of treating patients with chronic pain in the emergency department? I know that here, talking with you, I'm preaching to the choir or the converted. You're all people who care about this issue. But when you talk to folks who aren't within academia, who aren't interested in prescription opioid misuse, or who are training up in our specialty, I think you'll see some commonalities with this issue, with these issues. Time constraints. And I think that's one of the most pervasive difficulties, is the fear that having a long conversation with patients about analgesia will distract you from other more critically ill patients. The next. Anticipating the fact that there is going to be dissatisfaction. So you know that you're setting yourself up for a difficult interaction with a patient. Trying to establish your role within treating chronic pain in the emergency department. Feeling like you're giving in to giving opioids. Overcoming your own biases, being aware of the fact that there are certain populations that you may be less or more likely to prescribe to. Having concerns regarding the safety of prescribing medications, particularly in patients who are already on high-dose opioids. Having a lack of good alternatives. Feeling like it's impossible to truly know these patients. Trying to identify drug seekers, because if you believe, and I do, the chronic pain literature, drug seekers as a proportion of patients who are overall maintained on opioids represents a fairly small proportion, and we'll talk more about that in just a second. And then providing inconsistent care. So feeling like your colleagues are doing something entirely different for their patients than you are. Okay. So approaching each one of these, we're going to just talk about a case that probably all of you have seen in your emergency department. This is a young guy. He's healthy. He comes in, he says, I was helping my friend lift a couch. I felt bad. They were moving something heavy, and so I went and I moved it, and now I have terrible, terrible back pain. He has a history of a laminectomy that was performed 3 years ago. He says his pain is the most severe pain he's ever had. But he's sitting comfortably on the edge of the bed. His exam is reassuring. You find no focal neurologic deficits. You're not concerned that there's a new pathology today. He tells you this is an acute exacerbation of his chronic pain. And the patient is maintained on OxyContin 80 milligrams 3 times a day for chronic pain. He requests that his pain be treated with intravenous hydromorphone, and he asks for Percocet for breakthrough pain. Has anybody ever seen a patient like this before? Right? Okay. So in Massachusetts, unfortunately, and in Rhode Island, my prior practice environment, unfortunately, this is all too common. And what we find are that we're often treating a population of young patients who've been disabled by an injury, who are maintained on high doses of opioids, and then they enter this sort of revolving door where they're seeing their primary care doctor, they're coming to the emergency department for exacerbations of pain. We're in a very close tri-state environment, so you'll be like, didn't I see you in Rhode Island? You can see these patients moving from Connecticut to Rhode Island to Massachusetts, and I know Ed will be talking a little bit more of reciprocity of PMPs in the next session. So, time constraints. I have no great solution for time constraints, except to say that the more you do this and the more you think about this, the easier this becomes. And part of the reason that I'm here talking to you today is because I used to dread dealing with this patient population. For me, primarily, it was the lying. And it was sort of the befuddling aspect of this patient population where you ask yourself, this is your 6th presentation for chronic abdominal pain in the past 3 weeks. Is today the day that you've got gallstone pancreatitis? Is today the day that you have an SBO? Or am I simply treating the same thing you've had in the past? So the time constraints are both applicable to not just the conversation, it's the time to administration of an opioid. If you're going to start an IV and give this patient hydromorphone, it's waiting for analgesic effect, it's waiting for the patient to be ready to leave the ED, or it's all of the additional imaging and testing that you're going to do. And I would suggest that when you actually kind of step back and say, I'm going to approach this from a chronic pain paradigm and talk to you as opposed to initiating opioid treatment, particularly parenterally, or initiating imaging, that this actually may be time saving. We're going to anticipate potential dissatisfaction. So what are some of the consequences of deciding that you're not going to treat a patient like this with opioids up front? You may be guilty of oligoanalgesia, and differentiating pseudo-addiction from sort of, we'll get rid of the term drug seeking later, is very challenging in our environment. We just don't have the track record with these patients. So you have to accept the fact that if you're not prescribing to every patient, you are going to undertreat pain in some cases. You may generate conflict. Your patient may be angry with you despite your best efforts. Patient satisfaction metrics, which have become increasingly important in some environments, may suffer. However, I think there's a lot of literature kind of forthcoming to suggest that that link is not as robust as we think it is. And perhaps it's just the larger denominator of patients who don't require opioid analgesia that are kind of diluting that effect. Mostly what we find patient satisfaction is linked to is actually wait time. However, I feel like anybody who answers complaints for their emergency department will see complaints generated about inadequate analgesia. Doctors are worried about facing sanctions, although the proportion of sanctions is so much higher for inappropriate prescribing of too much analgesic than it is for too little. And then the last concern that's always there is a concern of violence, and I think that's real. So do I have a role? Is this my problem? I think that after listening to Dr. Todd's discussion, the answer to that is a brief yes. And I think that we have to sit at these tables, we have to be a part of this discussion, but also our goal is to provide care, and care is different than providing analgesics. So am I giving in when I'm giving opioids? And perhaps those of you who work with residents have had a resident come out and say, I'm going to send them out with a prescription for Motrin, and they're patting themselves on the back because they feel like they're sending out a chronic pain patient who's addicted to opioids with an NSAID. I think you have to be really careful when you define victory in this population. And I think that the reason that you have to be so careful is because if we're bad at assessing pain, I think we're worse at assessing suffering. And I think a lot of these patients who come into us aren't necessarily coming in for exacerbations of chronic pain. I think they're coming in for untreated depression, they're coming in for their intimate partner violence, they're coming in because of concerns about financial viability. The list goes on, and I actually find that most of the time, if you're willing to spend the time, you can find alternatives. I shouldn't say most of the time. You can often find an alternative to an opioid, and I'll give you an example. A woman comes in with chronic back pain who requests an opioid, and you say, what are you most concerned about? And she says, I have to go to work as a housekeeper for the next 3 days, and I have to be able to work. And you say, if I write you a work note so that you can get 3 days worth of rest, will your employer accept it? And she says yes. Well, there you have sort of a short-term solution to the problem that allows her to see her primary care doctor, allows her to kind of adopt a treatment regimen that we think is most appropriate in terms of rest or NSAIDs, assess her improvement, and then either potentially go back to work or see her primary care for an extension of time out. I think the other thing that we have to be careful about in defining victory is that there are unintended consequences when you're not careful about how you set your metrics for success. So if we say our metric for success is simply that we prescribe less opioids, you have to be very sure that you're not seeing a rise in something else like, say, deaths from heroin abuse. I think the other thing that we've found in our population, and granted, it's the tip of the iceberg, we're toxicologists, we're dealing with a fundamentally different group, is that we've seen at least 2 completed suicides in the past year whose suicide note referred to the fact that they had chronic pain. And these were patients who, in both cases, had had multiple emergency department visits through multiple hospitals, frequently denied opioids, inconsistently given opioids, but their suicide notes, and these were both 20-year-old men, actually said, I'm tired of being in pain, and I'm tired of no one caring about me, and one of them actually completed with a verapamil overdose. So, are we biased? And we all have biases, and I think Dr. Todd already mentioned the, the studies that sort of established the era of racial disparity. And in my own personal practice, I started my training in 2000. What I found was that this literature initially was very compelling in terms of prescribing more analgesics. We were underprescribing. We were underprescribing to certain populations. We were guilty of oligoanalgesia for things like long bone fractures. That disparity continues to this day. What's interesting are there's some other biases that you may not be aware of. I found this paper fascinating. This is one of the toxicologists on this paper, David Lee, has talked about their results, but they talk about education being a factor in receiving opioid analgesics. So the less educated you are, the more likely you are to receive an opioid analgesic after your ED visit. And they had standardized this to patients who had been in car accidents, and they actually standardized this to non-Hispanic whites. So they were looking at one ethnic and racial group in particular, where they found that if you had the highest educational attainment, specifically college, you were 3 times less likely to receive opioids than patients with the lowest educational attainment. And they found that this was larger than differences previously described for ethnicity or sex. For me, this sort of raises the question of whether the patient's healthcare literacy plays a role in their acceptance of a non-opioid analgesic plan. And I think that our role in this is becoming better communicators, better educators in terms of the role of opioids in treating pain as well as the risks of opioids to our patient population. And this is one of Dr. Todd's papers. I love this. It talks about the fact that women providers are more likely to prescribe, but not just that. Women are more likely to prescribe to women patients, and men are more likely to prescribe to men. So in terms of the biases that we all are guilty of in our practices, I think the 2 most important ways that we try to combat bias are, one, that we adopt a disease-based approach to analgesia, where you have a standardized approach, for example, to low back pain, where we have guidelines and we have evidence that guides us against the use of opioids. And we continue to study analgesic disparities because they arise in the most unexpected places. So concerns regarding safety, and this is dear to my heart as a toxicologist. This is from Dr. Pelosi's work. This is from the MMWR in 2000. What you find here in black are the patients who have more than 100 morphine, excuse me. Oh, there we go. I apologize. These are the patients who are receiving less than 100 morphine equivalents prescribed by one doctor. The blue is more than 100 morphine equivalents prescribed by one doctor. And then the gray are patients who are receiving an unknown amount of opioids because they're receiving it from multiple providers. What you find is that the population who is getting that sort of lower dose, and not that 100 morphine equivalents is a low dose to start with for a daily dose, but people who are receiving less than 100 represent less than 20% of the overdoses, while patients who are receiving 100 morphine equivalents or more represent 40% of the overdose deaths. So when you look at this, there are a couple things that I think we can take away from that. One is that in our patient, for example, the gentleman who's on 80 milligrams of OxyContin TID, I would be very careful about adding an opioid, whether it's a short-acting, or hopefully no one in your emergency departments is typically prescribing long-acting opioids. If you have a scenario where you have to adjust a medication regimen like that, for example, that same patient comes in with a wrist fracture, that's a good time to involve palliative care or pharmacy, just because we're not experts in titrating these longer acting opioids. And despite what most people think, patients who are tolerant to a high degree of opioids may not experience a wider therapeutic window. In fact, it may be narrower. Their distance to the cliff of respiratory depression may be shorter. The last caveat is to avoid combination with benzodiazepines. And so if you have a patient that comes in for anxiety, they come in for muscle strain, who's on methadone, who's on OxyContin, I think it's unwise to actually initiate a benzo at that point. The lack of good alternatives, and I feel like this is something that's frequently raised. So I think this comes from our patients, because our patients have been telling us that opioids are effective for pain. But when you go back to the literature and you ask the question, are opioids effective for chronic non-cancer pain? The answer is that there's really a paucity of evidence to show their safety or their effectiveness. So this is just a wonderful editorial from Annals of Internal Medicine from 2012. It says that perceptions that long-term opioid therapy typically yield long-lasting benefits for patients with chronic non-cancer pain are not supported by strong evidence. They also go on to say that modest reductions in pain have been reported during the 3-month duration of most trials. But prospective studies looking out greater than 3 months show that they don't really improve function in the vast majority of patients. In fact, what they find is that the majority, 60% of patients actually abandon opioid therapy due to a perceived lack of response or due to adverse events. Contrast that to NSAIDs, and Dr. Todd already spoke a little bit about the evidence for NSAID use in back pain. It's there in dentalgia, it's there in migraine. There's much more supportive evidence for the use of NSAIDs. So when you're looking for good alternatives, I think that we have to be aware of these two competing bodies of literature and look for the Cochrane reviews or the randomized controlled trials that actually compare NSAIDs versus opioids for chronic pain. It's impossible to know these patients, and I think the use of objective data sources like prior ED visits, prior documentation, looking at your EMR, looking at the PMP is essential. And then the next question becomes, how do I identify a drug seeker? Looking at one of the few prospective studies examining drug-seeking behaviors in the emergency department, some of the things that you would expect come up with high odds ratios in terms of studied behaviors that predict drug seeking. And in this study, the gold standard for drug-seeking behavior was referral to drug treatment. Requesting parenteral opioids, greater than 10 pain, more than 3 visits in 7 days were the highest. Some of the things that you might associate with drug-seeking behaviors like headache, dental pain, and non-narcotic allergy actually came in with lower, but still positive odds ratios. I think the thing about this, though, is that it's such dated terminology, and I've been trying as much as possible to get my trainees to avoid it. So I love Tracy Green's paper talking about the typologies of prescription opioid use, because she actually takes this population and breaks it down, I think, much more intuitively, but also much more specifically into the following 4 groups. Are you somebody who has chronic pain who uses your opioids as prescribed? Are you somebody who is prescribed opioids but is still guilty of misuse? Perhaps the person who comes to the emergency department whenever they feel like they have breakthrough pain. Are you someone who's medically healthy, who's an abuser? And this can be the person who's buying on the street versus the person who has no documented illness or injury, but we've put them into this cycle of opioid and opioid and opioid. And then the last class are the illicit users, people who are actually guilty of criminal behavior. They're forging prescriptions, they're selling, things like that. And when you stratify our population into these groups, well, then you can understand the fact that the treatment is going to be guided by this typology, For example, if you're somebody who uses as prescribed, who comes in with an acute injury, perhaps the treatment should be an analgesic. For example, the person who has a wrist fracture. If you're perhaps the treatment should be better contracting, where we're communicating closely with your primary care doctor about your use of the emergency department for analgesics. Medically healthy abusers, I think that we have to look for the underlying illness and make sure that we've got an accurate diagnosis, but there's no role for opioids here. And illicit users, unfortunately, this is not something that may be dealt with medically, but maybe have to be dealt with by law enforcement. So finally, inconsistent care. How many of you have had the experience where you have this totally rational conversation with a patient about how you're going to use NSAIDs and muscle relaxants for their back pain, and they said, but the last time I was here, the doctor gave me 50 Percocet. Has anybody had that happen? Yeah. And the last time that happened, it was a patient I saw with dentalgia who said, but your partner, and he identified my partner by name, gave me 50 Percocet the last time I was here with a toothache. And I was like, yeah, sure. I looked in the computer and it turned out it was true. So I think the hard part is that whatever our plans are, they're going to fall apart in terms of this inconsistent care model because they're getting different opinions from different providers, and oftentimes these providers are all excellent docs who fall out differently on the scale of oligoanalgesia versus the risk of opioids. We have to, at a department level, at a state level, come up with what we think best practice is. And you'll be hearing more about that today. So in our patient, are opioids indicated? How many people would say yes for the patient that we talked about? And again, it's sort of a kind of heavily weighted audience. I think that in order to make the decision, you ask yourself some questions. You look for objective information. He's had 12 emergency department visits in the past 8 months for similar pain. He's got 6 currently active opioid prescriptions in the PMP. You do a functional assessment. He's sitting there comfortably on the side of the bed, ambulates well. You can't necessarily assess his experience of pain, but you can certainly assess his functionality with his back pain. You look for the evidence base, and fortunately there is one for low back pain, and then finally you make a risk-benefit decision. Is it in his best interest for me to add another opioid? And at this point for this patient, I would say no. So now the key is in the delivery, right? And I think that what most patients are looking for, because I think a lot of our patients really are educable. I don't think that opioids are the best treatment plan for you, but it has to come from a perspective where you actually care about this patient. And it has to come from a perspective where you validate their suffering. So sometimes you may say something like, I'm really sorry that you're in so much pain, and if I had a magic bullet to take this away, you know I would. How long did it take you to get better the last time? Oftentimes these patients will say 2 weeks. I think that's what you can expect this time as well. Today's plan is that we're going to treat you with Motrin, we're going to treat you with a muscle relaxant. You can offer alternatives. Has Robaxin or Flexeril ever worked better for you in the past? Explain those medication choices. So you say things like, I have nothing stronger than the medications that you're on, and unfortunately if I add an opioid, I'm afraid I might put you at risk of death. So this is what we're going to do. I expect your pain is going to get better over the next couple of days. It's going to get even better over 2 weeks since that's what you experienced before. I want you to follow up with your doctor in the next couple of days. I want you to come back if anything gets worse. I would expect a response. And I would expect, if they've been pre-programmed that opioids are the only thing that works for their pain, or that your partners have given them 50 Percocets in the past, that response may be negative. You're not listening to me. You're not doing what I expect. This is not what I came here for. This is not why I waited for 8 hours in your waiting room. Ultimately, what I think you have to say is that either I don't prescribe opioids for this kind of pain, which takes the patient out of the equation. It's not because of you. It's because of your symptoms. Or you can say things like, I'm sorry I can't meet your expectations today. I find these conversations very hard, and I'm sure many of you have better techniques for dealing with this, but unless we share, we refine, we work on these scripts for managing patients, it's going to be very challenging. And then finally, I would offer to coordinate their care. Can I call your doctor? And the reason I would say that is because oftentimes the doctors say, oh, sure, he's great about getting his medications on time. Please go ahead and treat him. I'll see him first thing in the morning. And that's so satisfying. Or they'll say, I'm worried about him. I'll see him first thing in the morning, and we're going to go over his regimen. Unfortunately, a lot of our patients don't have primary care doctors, and I think that's a bigger system-wide issue. So we talked about these scripts. Our goal is to take the 10 obstacles that you see at the bedside and turn them into 10 strategies. And I'm sure all of you are already doing this. It's just more of a way to convey this to your trainees. I'd be happy to take any questions, and thank you for your time. Thank you so much.
Do we have some questions or comments? Okay, it's a pretty passive audience, but we'll live with that and introduce our next speaker who, oh, we have a question. Okay. That's a great question. So the question is, how would you manage withdrawal? So in the case that we were talking about, we assumed that the patient was receiving some sort of opioid from a primary care doctor, and that was a long-standing prescription. But we certainly do see those patients, and I think the trickiest patient population that we deal with withdrawal for, and I don't know how many of you folks have had to manage this, is when a doctor gets disciplined. And so how many of you guys have had like the influx of a large chronic pain population when a doctor gets their license yanked? That's extraordinarily hard. And so a couple different populations. So for the patient who comes to the emergency department in withdrawal, who has a primary care doctor, I think there's a good opportunity for care coordination there, and whether their doc says, yes, treat them, or treat them symptomatically with clonidine, with antiemetics, and I will see them in the office tomorrow. I think that's reasonable. For the patient who has no doctor, it becomes a lot more dicey, and I know that some programs in Massachusetts, such as BMC, actually have the opportunity to start buprenorphine in the emergency department. I think that's a nice alternative. It's not an avenue that's open to a lot of EDs. What we can do is we can, in our setting, refer patients to inpatient opioid detoxification. And so there are programs in our community, and I think it's essential that everybody knows where you can, if you can, refer these chronic opioid patients out. Occasionally we'll see patients with significant enough withdrawal symptoms that they have to come into the hospital medically for intractable vomiting. And that's another population that we've had to manage. But for that last population, the population who loses access to opioids through essentially no fault of their own, what we've found is that we've been able to get other physicians to pick up their care. The HIV immunology teams in particular have been very open to prescribing Suboxone. It's so difficult to look for a provider to de novo start prescriptions like OxyContin 80 milligrams TID. So it looks like we now have a bunch of other questions. Good.
Kavita, great talk. One question. How do you judge the relative risk of treating your patient, as an example, with an intravenous opioid in the emergency department versus prescribing for discharge? I found the patient who I feel like they manage the risk and the downside of intravenous opioids and parenteral opioids in the department. What I can't manage is the risk of the discharge prescription, and I tend to judge those two things differently. And I found patients who respond to that initial, whatever it is that's contained in that injection I give them, whether it's an opioid injection, whether it's maybe injection therapy, trigger point, whatever it is that I do, versus the risk for the outpatient. How do you do that?
I agree with you. I think that giving the opioid parenterally in the ED is just so much, it gives us the opportunity to be vigilant for any adverse events. It's funny because for the first time ever, I had a primary care doctor refer in to the emergency department a patient on methadone because she wanted him started on benzodiazepines for anxiety. So I think everybody is increasingly aware of these safety issues. That's scary. They're increasingly aware of these safety issues, and so this may become more and more of our problem. I will oftentimes give parenteral analgesia while I'm completing my evaluation, for example, for something like chronic abdominal pain. But if there are no findings to suggest that this is more acute than what the patient was being treated for before, I think the two options are, one, to bring those patients into the hospital for acute pain management, especially the patients that are on high-dose methadone or OxyContin, if you think that that's appropriate, or two, to discharge them home with their pre-existing analgesic regimen.
Okay, one last question, then we'll move on.
Thank you. Yeah, Lewis Nelson from New York City. So, I mean, obviously what you said is terrific, and I think we all have a lot to learn about how to talk to people. One of the problems that we face, and I'd love to know how you handle this, are the two issues that we constantly have to deal with in our practice. One of them is the CMS requirement for documenting adequate assessment and addressing of pain, and the other one is patient satisfaction, right, and complaint letters when we don't really do what the patient expects or wants.
So Dr. Nelson was asking about patient satisfaction and also about CMMS and the pain score, excuse me. So I was actually practicing in the emergency department, and I had a patient who has chronic pain who had 4 out of 10 pain when they presented. And when I asked them, is this your baseline? And they said, I have 4 out of 10 pain every day. Every minute of my life, this is what I have. And I had the patient's nurse tell me that they could not discharge the patient because the patient still had 4 out of 10 pain, and I had not made any improvement in their pain score. I think one of the things that I didn't mention in this discussion is documentation. And I think that what you have to do is to provide an analgesic rationale. So one of the things that I find is that if you get sign out, people are like, this is a patient with a healthcare acquired or a healthcare associated pneumonia. I'm treating them with vancomycin or vancomycin Levaquin. They'll give you a regimen. When you get sign out, inexplicably everyone will say the patient got some pain medication. And I think that we have to be very specific in our analgesic practice, and we have to document it as such. So I chose, if you write on that chart, the patient always has 4 out of 10 pain. I discussed it with nursing. We're going to discharge them home with the following. This is their follow-up plan. I can't imagine that that's not going to satisfy the kind of regulatory aspect of this. But ultimately, if it comes down to it, I would support my practice with analgesics with appropriate documentation rather than do something that I don't think is in the patient's best interest. The second question of patient satisfaction, we've looked at this issue before, and we've actually looked at this in our emergency department, and we did not find a link, specifically NED, with NED opioids versus patient satisfaction. I think the primary driver for that, again, is that wait time is just so much more important than analgesia, that you find that it gets watered down overall by sort of efficient flow by the denominator of the other patients who receive these surveys, because again, you can never predict who's going to return it. And finally, with complaints, our administration has universally adopted the approach that each individual prescriber is responsible for the amount of analgesic they think is appropriate, and those complaints, unless there are other parts of that complaint, get answered in that way. And I think there has to be policy at the departmental level that supports your practice.
Okay,
I think
it
I'm
looks
out
like
of
we have,
time.
well, we have, yeah, you are, but she's been waiting a long time, so I'm going to loosen things up. We are going to fall a minute behind, but if you have a quick question.
Thank you.
My question is in regards to the IV payment, which is in the emergency department. I find that frequently that is a request. We're not going to send you a prescription, but yet we will give you an IV dose of whatever your drug is in the emergency department. I'm wondering if there's any sort of strategy that you felt to choose an IV pain medication that's most appropriate. If you ever considered withdrawal as that drug rather than withdrawal.
Okay. And so the question was, when the patient requests an intravenous opioid, what are some of our alternatives, or what is our plan? I think the first thing is that if that's specifically the only thing that they're there for, is they say, I have chronic back pain and I'd like an IV dose of hydromorphone, that's not a request I can honor unless there's a functional element that goes with that. So if the patient is sweaty, lying in bed, can't roll over for an exam, then of course we should treat their pain. If the patient like this requests IV hydromorphone, I don't think it's appropriate in terms of cost, in terms of resources, and in terms of safety. So I frequently say, I understand that you've been treated with that in the past. I'm going to offer you either an oral analgesic or this alternative. What I think is the most dangerous practice that I've seen is people have started giving high doses of IM hydromorphone. So they don't want to give you an IV, but they're like, I'll give you a shot. And I actually found one of my residents once giving a patient 4 milligrams of IM hydromorphone. These are cases that Ed Boyer and I have to frequently review in sort of a different context. And the worst thing that I feel like an emergency physician can do is to take a patient with a non-life-threatening illness or injury and kill them with opioids. And this happens even in the in-ED setting, not just when these patients go home. With regards to buprenorphine, I wouldn't consider it for the management of acute pain in that setting. It has been used for analgesia in Europe, but the trouble is that if you have a patient who's already on chronic opioids, you can have precipitated withdrawal. So you may take a bad situation and make it significantly worse, especially if they're not forthcoming with their opioid use. But I think that your options there is that if you don't think that the patient requires intravenous analgesia, you can use oral analgesics, specifically opioids or NSAIDs. But it's going to take some time to sort of reframe their thinking about best practices. And the last thing that I'll say is that I don't meet with a lot of pushback. And I think it's because I spend a lot of time thinking about this. In part, I think the other thing is that when patients realize that a physician is not going to provide what they're expecting, they look for another physician. And so I don't want to be cynical about this, but the fact that I haven't met more resistance makes me think that folks are just moving on. But I do try to do as much care coordination and as much counseling as I can. And I actually try to put that down on their chart that we had prescription opioid counseling so that the next time somebody opens it up, they know that somebody's talked to them about it. Thank you.
Okay.